So thank you very much for the opportunity to present evidence on progress towards universal health coverage, drawing on the collaboration between WHO and the World Bank in addition to WHO own work. Next slide, please. Universal health coverage means that all people, no matter who they are or where they live, can receive the quality health services when and where they need them without incurring financial hardship. All 193 UN member states are committed to advance UHC by 2030 as part of the SDGs. And since 2015, WHO and the World Bank have been monitoring progress jointly to hold all stakeholders accountable and as a starting point for country-specific assessments. The latest report we published in 2023 is clear. We are off track. 4.5 billion people lacked full coverage of essential health services in 2021, and 2 billion people faced financial hardship due to out-of-pocket health spending on health in 2019. Why? Next slide, please. Too many countries still have low service coverage index scores. The current service coverage index score uses a basket of 14 indicators to represent overall coverage of essential health services across the entire population from 4 broad categories of service coverage: reproductive, newborn, maternal, and child health, infectious diseases, non-communicable diseases, and service capacity and access. It tracks crude service coverage, meaning that it doesn't capture if the services were of sufficient quality or quantity. In 2021, the country-level service coverage index scores range from 28 to 91 out of 100 index points. This is a massive improvement from the baseline score in 2000, with country score improving up to 39 index points over the past 2 decades. Most countries saw improvements of 20 to 29 points over this time period. However, we can see persistent low scores concentrated in certain areas. Next slide, please. Here's the service coverage index by its components over time. The infectious diseases sub-index drove progress since 2000, improving on average of 7% annually at the global level. There was an abrupt plateau in progress from 2019. Meanwhile, the non-communicable diseases, reproductive, newborn, maternal, and child health, and the health service access and capacity sub-index saw only gradual increases through 2015, followed by no change or a deterioration in more recent years. Household survey data has shown that those living in rural areas, the poorest households, and those with the lowest educational attainment are the least likely to be covered by essential services. Next slide, please. The global rate of catastrophic out-of-pocket health spending, as tracked with SDG indicator 3.2, has continuously increased since 2000, our first reference year. In 2019, 13.5% of the global population resided in households that spend more than 10% of their household budget on health out-of-pocket. This is about 1 billion people. With respect to catastrophic health spending at the 25% threshold, which is the other SDG 3.2 indicator, we've estimated that the rate of increase ranged from 1.9% in 2000 to 3.8% of the global population in 2019. But even small expenditures that absorb less than 10% of the household budget in absolute terms can be devastating for low-income families. There has been a continuous reduction in the rate of individuals push or further push into extreme poverty due to out-of-pocket health spending, from 22.2% in 2000 to 4.4% in 2019. While this is an impressive reduction, it did occur during a period of overall extreme poverty reduction and is unlikely to be driven primarily by the reforms in the health sector to improve the affordability of health services and products. In fact, when we use a country-specific relative poverty line defined as 60% of median per capita consumption, we can see a continuous increase in the share of the population push or further push into relative poverty. Overall, in 2019, 1 billion people faced catastrophic out-of-pocket health spending, and 1.3 billion people faced impoverishing out-of-pocket health spending. Few people face both, since the overall estimated number of 2 billion people incurring financial hardship due to out-of-pocket health spending. Next slide, please. The most vulnerable populations face larger burden of financial hardship associated with out-of-pocket health spending. In this figure, we can see the median occurrence of financial hardship that is either catastrophic, impoverishing health spending, or both by income quintile in 92 countries. The likelihood of incurring such financial hardship is substantially higher for individuals in the lowest quintile. This is, of course, mostly due to impoverishing out-of-pocket health spending that affect those who live below or just below the poverty line. There are also variations in vulnerability across other household characteristics, not shown here, but when we've looked at other characteristics, we've noticed that households with older members or members above 60 years old, for example, are more likely to incur catastrophic out-of-pocket health spending. However, impoverishing out-of-pocket health spending is more prevalent in rural areas. In the report, we also present variation along other household characteristics, such as age composition of the household, and gender of the household heads. Next slide, please. The global pattern of lack of dual progress towards universal health coverage is consistent across all geographical regions and country income groups, as well as across most countries. Indeed, since 2000, 96 of the 138 countries with trend data on both dimensions of UHC made no progress in reducing catastrophic health spending, while service coverage improved. The left-hand side figure showed that these 96 countries with worsening or little change in catastrophic health spending are spread almost equally across almost all income groups. But the concern is that the improvement observed in service coverage until 2000 is not visible anymore after 2015. In fact, since 2015, progress towards universal health coverage is also hindered by the deceleration in service coverage as its expansion stalled or worsened in 108 countries. But the right-hand side figure shows that such lack of progress in service coverage in 2015 is not equally distributed across country income group levels. It prevails in upper middle income countries, and in lower middle income countries, the proportion with and without improvement in service coverage since 2000 is almost equal. Next slide, please. In addition to the SDG tracking, WHO Impact Framework also includes SDG-based triple billion targets aligned with three priorities: promote, provide, and protect. Healthy life is also included as an overarching summary measure of population health, and there are also outcome indicators that cover a range of health issues which are aligned with country and regional strategic priorities and measured through outcomes of the program budget. Based on this triple billion target, the world is also off track to reach most of them. The healthier population billion is the bright spot, with 1.55 billion more people expected to have better health by 2025. Yet for UHC in the middle graph, efforts need to be redoubled to reach 1 billion by 2025. Given the commitment and efforts of member states and the global community at the time this forecasting was made, progress on better protecting people from health emergency, that is the third graph, was more optimistic than for UHC, but still insufficient to reach 1 billion by 2025. Next slide, please. Looking at other outcomes, of which nearly all are SDGs, only 4 are on track: tobacco use, tobacco control, family planning, and health security. Only 6 more are making progress through falling short of the goals: TB and HIV treatment, malaria prevention, child immunization, child treatment, and hospital access. There is progress, but not enough to reach goals. The remaining indicators are off track. Of note are water and sanitation, clean household fuels, road traffic death, clean household fuels, air pollution, alcohol consumption, cardiovascular diseases, management of diabetes, and pregnancy and delivery care. These are notable because there are proven and affordable means of improving all of them, and doing so would have enormous health benefits, particularly for the most neglected population. But this needs to be done at a scale. Next slide, please. To assess and demonstrate tangible impact, improving the health of all individuals worldwide, in addition to the triple billion target, WHO also monitor progress on healthy life expectancy to measure impact at the highest level of the result chain. Indeed, Halley quantifies expected years of life in good health as a measure of overall health of population. And there has been significant improvements in healthy life expectancy at birth at the global level from 2000 to 2019. However, the forecasted progress is tempered for the next 3 decades, largely due to a slowdown in improvements in mortality. Halving premature mortality and improving quality of life at all ages will put the world back on track by 2050. Next slide, please. Coming back to UHC, recent multiple crises exacerbates the challenges to reverse the course and get back on track. Governments must urgently advance both expansion of service coverage and reducing financial hardship, and where needed to progressively realize this objective to reach the most vulnerable first. Everywhere, however, there are countries that have made progress in improving service coverage and reducing catastrophic health spending. I believe we will hear from some of them actually right after my presentation. So overall, to make progress towards UHC, we need strong political commitment, expansion of service coverage, while also meeting growing demands and changing needs through a comprehensive package of essential health services, including treatments. We also need to address the extraordinary increasing burden of NCDs, for example, which is a challenge in many countries. And for that, a strong PHC system is key to ensure expanded coverage. We really need to limit out-of-pocket health spending with low, fixed, and cap co-payments for those from whom user charges are still collected, and remove completely user charges for the poor and the most vulnerable. We also need to use public health funding efficiently and equitably. We need to absolutely intensify the monitoring of service coverage and financial protection with a focus on inequalities to make sure no one is left behind. Thank you. That's all for me.